Hi, I'm Alvin Wells, the Director of the Rheumatology and Immunotherapy Center in Franklin, Wisconsin.
And I'm Orrin Troum, a clinical professor of medicine at the Keck School of Medicine at the University of Southern California and in private practice in Santa Monica, California.
We're excited to bring to you a new education opportunity for rheumatologists, a new site called rheumatologyeducation.com. Today, Orrin and I are going to discuss some of the new imaging guidelines. These have been proposed by EULAR, actually it's been a number of years now. It came up with 10 different recommendations, and the recommendations include how to make the diagnosis, when to do monitoring, and also for prognosis. Prognosis for who's at increased risk for damage, but also a prognosis in response to therapy. They also talk about monitoring the disease, which joints you want to image, and then how do we use imaging for future endeavors. So Orrin, first I want to talk about what do you use in your practice? Do you use conventional radiography? Do you use MR ultrasound? How do you use those on a daily basis?
I think in my practice, and what was proposed by the EULAR guidelines, is that we are not leaving conventional radiography behind. They have still advocated the use of x-rays of the hands and the feet to be done initially, but also many of us are using ultrasound and MR as a prognostic indicator.
I agree, and I think just like Orrin's point says, right now for all the clinical trials, for FDA approval, and for approval for other agencies, conventional radiology is what we use. But the EULAR guidelines talk about other imaging diagnoses. Now, we pride ourselves on being a clinician, but it definitely tells us that the MR and ultrasound can detect more synovitis. So which joints do you look at, Orrin, when you're thinking about MR, when you wanted to rule out synovitis?
Typically not just for synovitis, but also osteitis or bone marrow edema, which is the distinct property that MRI has to predict and is the best predictor of future erosions. Typically the small joints, the hands, wrists, and feet can be imaged.
Now, like that, and this is really true. So unlike the MRI, the ultrasound does not show bone marrow edema. I get asked all the time which joints you look at. For the clinical trials, we look at 28 different joints. Studies we're looking at can we look at 10 joints. But the goal, and the EULAR talks about this in their guidelines, they can get the examination down to 15 to 20 minutes. You can highlight whether you're looking at 5 or 7 joints. It turns out with the ultrasound, the wrist and the second and third metacarpophalangeal joints are the ones you want to highlight the most. Orrin, when you look at the MRI, what about the MTP joints? Any dishes there? Which joints you want to look at when you think about the foot?
Typically when you get an MR of the foot, you're going to get the whole foot, but the fourth and fifth are the ones that are typically seen first. I would just also mention of the fact that in the EULAR guidelines, other issues were brought up, somewhat different from ACR recommendations, including the prognosis and that advanced imaging can be used for prognostication, and also to assess remission and then for monitoring. And this is somewhat different between the EULAR and ACR guidelines, but EULAR made those specific recommendations with the data that they had access to, and I think warranted.
Orrin, you bring up a very good point because I get asked all the time, not only by other physicians, but by patients, what do you do to monitor the disease? And how do you begin to say who can ramp up their therapy and who can taper off the therapy? So do you use an MRI to help you make the decision to add a biologic, to taper a biologic, to change drugs? How do you use that in your practice?
I may use MR and also ultrasound initially to see or to prognosticate which patients are at highest risk. Those that have the most synovitis, tenosynovitis, or with MRI with osteitis or bone marrow edema, I might be more prone to using advanced therapy quicker.
I think that's really true, and I think echoes what I do in my practice as well. I still pride myself on my clinical exam. I do a CDI, I do a DAS on patients, but there's some patients that can still be difficult. Where they have more hand disease or foot disease, we definitely know that ultrasound and MR can actually give us some guidance for that. What do you see the future of MRI as far as clinical trials or for using in routine practice?
An important point, and with the validation, and there is a validated scoring system, the RA-MRI scoring system that is useful. I think ultimately MR is going to be more useful for clinical trials as there are going to be fewer patients that are needed in a shorter period of time used for those clinical trials. I think that pretty much summarizes what the EULAR recommendations have made as of the past few years and where we're going to go towards in the future.
I think that's a good summary. I think here, again, to reiterate, Orrin and I, we go around the world, we go to all the different meetings, and we're really excited to see where we're going to be using imaging. Whether using conventional radiography, ultrasound, and MRI, imaging plays a significant advancement in our role as a rheumatologist. So again, thank you for your time. I also invite you to click on rheumatologyeducation.com for continued updates and new scientific data. So Orrin, thank you for your time.
Thank you, Alvin.